Hello everyone, myself Dr. Anurag Tiwari, and today I will be demonstrating arthroscopic ACL reconstruction in a ACL deficient knee. So this is a technique which is done arthroscopically. So this is the camera view you are seeing. So I made the anterolateral portal, the standard anterolateral portal just lateral to the patellar tendon, and I have done the diagnostic scopy. Now I am doing making the anteromedial portal. So anteromedial portal, this needle should be inserted just above the medial meniscus and in front of medial femoral condyle. After this, you will just insert the knife through the needle tract. So this is the medial meniscus, this is the medial femoral condyle, and this is the tibial articular surface. The knife should be just above the medial meniscus, otherwise you can injure the medial meniscus, and in just front of the medial femoral condyle, so that this trajectory will directly go to the notch area where the ACL is inserted. So I have dilated the tract with the help of artery forceps, and through this portal, through this anteromedial portal, you will insert the shaver blade and you will shave off the extra synovial tissue, the debris or any loose fragment or a foreign body or the fat pad, so that your visualization become easier. Be careful that when you shave the shaver blade, the blade part or the cutting edge should be facing towards the surgeon. Otherwise you don't know that which structure you are cutting. So for the safety wise, it is essential that you should keep your shaver blade in front of you, and the cutting area should be in just front of the camera. So this is on the lateral compartment side, the extra fat pad and the synovium is just getting shaved off. Once the fat pad and the extra synovium gets shaved off, you will be able to see the clear picture of the entire knee. So on the front side, you are seeing the lateral femoral condyle. On the inferior side, you are seeing the tibial articular surface or the superior surface of the tibia. And now we are moving on to the notch area. So this is the notch area. This white structure is the ACL that has been detached from the femoral insertion and is lying just close to the PCL. This is the PCL. These fibers are of the PCL which are originating from the medial femoral condyle and is going posteriorly and is getting inserted onto the posterior surface of the tibia. This red marked is the empty notch sign. Here is the insertion of the ACL, which has been detached and is lying flat. So we will be just debriding the ACL. These all fibers are of the ACL. So once we have debrided, the clear picture you can see. On the posterior aspect is the PCL. These shiny fibers which you are seeing is the PCL. And the notch has to be clear before making any tunnel in the femur. So adequately debrided, any remnant fibers has been cleared. And now you will take the aimer or the offset. Depending upon the diameter of the graft, you will take the adequate aimer and you just attach onto the edge of this lateral femoral condyle. You will insert the bead pin or the guide wire. Flex the knee about 110 to 120 degree on this position, and you ream the bead pin through and through both the cortices. getting you the clear picture. Once the bead pin has been reamed, over this you will insert the endo reamer, that is a 4 mm or 4.5 mm reamer, over this guide wire. You can see the fat globules which are coming from the reamer, from the marrow. You can even check the length of the tunnel. So this is the length, this is depth gauge. So this is coming around 40 mm. So the total length of the femur is of 40 mm. Removing the depth gauge. And now you will reinsert the guide wire or the bead pin through the same hole, and over this bead pin you will run the reamer of the appropriate diameter. So whatever the diameter of your graft is, in this case it is 9 mm. So I will just use a 9 mm femoral reamer. The femoral reamer is of flower tip. So over this guide wire I will just insert the 9 mm femoral reamer and will ream the femoral socket. Now the length of the femoral socket is variable. It depends upon whether you are using a fixed endo button loop or the adjustable. So I am using, in my case, adjustable endo button. I usually drill up to 20 to 25 mm of the length. So this is the 20 and this is 25. So 25 length has been reamed adequately. So this, you can see the mark is 30th mark is on the outer side. So 25 mm has been reamed. This has been confirmed. So you remove the reamer and you remove the bead pin. After debridement, you will see this picture. The beautiful tunnel aperture is visualized. And now you insert the bead pin. And over this bead pin, there is an eye on the distal side, and through this eye, you will attach a fiber wire or ethibond or any suture. This is the suture. So to shuttle this suture through the anteromedial tunnel to the femoral tunnel and outside the femoral cortex. So this has been done. So the sutures are being shuttled from the anteromedial portal to the femoral tunnel. Now you can extend the knee up to the 90 degree, means flexion can be reduced, and this is the tibial jig. So this is a elbow jig or elbow aimer. So very careful, you should be very careful while using this type of jig. The guide wire will exit through the elbow portion. It's not from the tip, it's through the elbow. This is the anterior horn of the lateral meniscus, or the anterior attachment of the lateral meniscus, which you are seeing. It should be just posterior to the guide wire should exit just posterior to the lateral meniscus. So this will be the projected trajectory of the guide wire, and you can see here, this is the marked, red marked, or the circle is the anterior horn of the lateral meniscus. So I am sure that this position is adequate. So I will ream while inserting the guide wire, while fixing this jig at this appropriate position. So just attach the bullet into this jig and you ream the tibia tunnel with the tibial guide wire or the bead pin, or K wire can also be used. So this is the guide wire. So the position is correct. I am satisfied with this position, so I will just confirm this. You remove the jig and you fix this guide wire with the help of artery forceps, and you drill the tibial tunnel with the adequate size reamer. In this case it is a 9 mm graft, so I will use the 9 mm tibial reamer. The tibial reamer is a non-flower tip, whereas the femoral reamer is a flower tip. So that is a way to differentiate between these two. So just this reamer has, the reaming has been completed. You remove the reamer. Be careful when you are reaming the tibial tunnel that the camera should not be just in the path of the reamer, otherwise you can damage the lens. This is through the tibial tunnel, the visualization. This is known as tunneloscopy. So this confirms that there is no blowout of the tibial tunnel. The tibial walls are good enough. There is no blowout, there is no complication. Again back to the anterolateral, through the anterolateral portal. Now is the time to shuttle the sutures from the femoral side, which are being in the anteromedial portal. We'll take them back to the tibial side. Just reaming the edge of the tibial aperture. Sometimes the graft gets stuck in this tissue. And you take the suture retriever or the depth gauge, as in this case I have taken the depth gauge, so you can retrieve the sutures through the femoral tunnel to the tibial tunnel. Now the sutures are passing through the femoral tunnel and the tibial tunnel. Now we have attached the graft to these sutures, and now the camera is through the anteromedial portal. So you can see the end-on view of the femoral tunnel which we have drilled through the anteromedial portal. So these are the threads which you are seeing. These are being pulled through the lateral femoral cortex, and this will pull the graft. So these are the threads of the graft, the sutures which are attached to the endo button. Just shaving a little bit in order to give you a good visualization. You can see the beautiful femoral tunnel, and these threads are just, we are pulling these threads through the outer femoral cortex, and you can see the endo button. This shiny titanium endo button is just going inside the tunnel. We will move inside the tunnel. Now you can see the endo button. So this tunnel is just going at the edge of the cortex, and at this point now you can flip the button. So this is the flipping has been done. It has been adequately flipped. When you pull now the graft, the button will not come out. It has been flipped and is fixed onto the lateral femoral condyle cortex, the outer cortex. Now when you pull the adjustable threads over this endo button, the graft will be pulled into the femoral socket. So here you will pull the adjustable sutures, and this is pulling the graft. So the graft is coming from the tibial side and is now entering into the femoral tunnel or the femoral socket. So this shiny white structure is the new graft or the new ligament, 9 mm in diameter. This is peroneus longus tendon, and this is a vicryl mark which we have made in the graft at 20 mm from the end. So this will ensure that the 20 mm graft has been adequately gone inside the femoral socket. So this vicryl mark, there is a separate video on how to make a graft and how to harvest the peroneus longus. So through the adjustable threads we have now adjusted its length. The loop length can be adjusted, and that's why we have pulled the graft into the femoral side. So this confirms that adequate around 18 to 20 mm has been inside the femoral tunnel. Now we remove the camera, we do the cycling, and we will fix the graft on the tibial side with suture disc. After fixation on the tibial side with the suture disc, we can again pull the graft onto the femoral side using the adjustable threads. So this is after the final fixation. You can see very well fixed graft from the tibia, from the femur onto the tibia, and using the probe I can see there is a great tension in the graft. This looks good. There is no impingement, there is no blowout, and the knee looks good. So this is the picture you can see on the femoral tunnel and the tibial tunnel we have drilled. On the femoral side we have fixed the graft with the endo button. In this case we have used the adjustable endo button. And on the tibial side we have used the suture disc in order to fix the graft. So this is a suspensory type of fixation. And these white fibers are of the native ACL. We have preserved the remnant of the ACL on the tibial footprint. This is again important because this gives a good proprioception and a good fixation in the graft. Okay, thank you so much.